Okay, distinguished professors, all of our audience online, good morning and good evening. Welcome to JACC Asia webinar series on epidemiology. I am Dr. Wang Jian'an, the editor-in-chief of JACC Asia from Second Affiliated Hospital, Zhejiang University School of Medicine, China. It is my honor to chair this webinar together with Professor Jian'an Wang from Heart Disease Prevention Program Division of Cardiology, University of California, Irvine, and Dr. Eugene Yang from Division of Cardiology, Carl and Rennie Bank Edward Professorship for Aging Healthy University of Washington School of Medicine. Also online today, we are very honored to have Professor Doraraji Prabhakara from Center for Chronic Disease Control, Public Health Foundation of India, New Delhi, India. Dr. Wu Yangfeng from Peking University Clinical Research Institute, Peking University, Beijing, China. Professor Tomonaru Okamura from Department of Preventive Medicine and Public Health, Keio University School of Medicine. Professor Hei Chong Kim from Department of Preventive Medicine, Yonsei University College of Medicine, Seoul, Korea. Thank you all and welcome. As a cardiologist, many of my patients asked me, what is this disease? Why I'm getting that? And what does the future hold for me? And the discipline of epidemiology gave us an answer to it. As the first regional journal in the JACC family, one of our missions is to understand the cardiovascular disease in aging population, better bridge the gap among countries. Apart from the original research, we also focus more on the cross-disciplinary studies, where aging researchers hold a competitive edge and comparative studies between Asia and the rest of the world, where epidemiology helps to understand the disease features of aging better. That is why the theme of today's webinar is epidemiology features of cardiovascular disease and the implication for prevention strategies and practice in aging countries. In the first issue of JACC Asia this June, we published a state-of-the-art review from Professor Zhao Dong. So without further ado, I would like to invite Professor Zhao Dong, the Deputy Editor of JACC Asia, the Deputy Chief Editor of JACC Asia, to deliver the keynote speech. Her topic is Epidemiological Features of Cardiovascular Disease in Asia. Professor Zhao, welcome you.
Thank you, Professor Wang. I would like to share my slide with everybody. Here, Chairman, Professor Wang, Professor Wong, and Professor Yang, and the distinguished panel member, and all audience online for this webinar. It's a great honor for JACC Asia to organize this webinar focused on epidemiology and cardiovascular disease prevention in Asia. As a first speaker, I would like to share with you a brief summary for the epidemiological feature of cardiovascular disease in Asia. I'm Dong Zhao from Capital Medical University, Beijing Anzhen Hospital. Asia is a home for 60% world population in 48 countries. So among the 41 million population in Asia, near 80% of them lived in the country in South Asia or country in East Asia. In last 70 years, there is a huge improvement in the population health in Asian population, which indicated by the 70% drop in the total mortality rate in this 70 years. Then as a consequence, the life expectancy increased dramatically from 42 to 73. So I think that's a very important background information. As the increased life expectancy at birth in Asian population, then we can find a remarkable change in the disease spectrum, even in recent 30 years. In 1990s, communicable infection disease also include a small part of the maternal, neonatal, and the nutrition disease. Mainly in infection disease actually is still a top cause of death in Asia. Since the 1990s, the percentage of infection disease decreased from 37% in recent 30 years, reduced to 15%. And the cardiovascular disease become a top cause of death in Asian population with a very important, become a very important issue in public health. I find that many literatures actually present the epidemiology feature cardiovascular disease in individual Asian country, but I didn't find the lecture or the review article to summarize the cardiovascular epidemiology feature in Asian, include all the Asian country. So as an invited review article, I summarized the epidemiology features cardiovascular disease in Asia. It's a great honor that this review have been published on the first issue of JACC Asia. And the data sources I used for this review, so mainly based on these 4 data source database of global burden disease, UN World Population Perspective, WHO Health Statistics 2020, and many literatures searched from PubMed. And I would like to share with you some features identified from this review work. The first feature is from 1990 to 2000, is almost 30 years, the crude CVD mortality rate increased continuously in Asian population. But on the contrary, age standardized CVD mortality rate decreased. So this slide show you is more with a more clear, detailed data. Total mortality rate, crude total mortality increased 36%, but the age standard CVD mortality reduced 27%. So it's very clear demographic change, especially the change in age structure in Asian population during the last 30 years, a main explanation for the CVD trend. Therefore, increased CVD burden, because here I use the mortality, the non-fetal cases. The burden include the non-fetal cases. So the increased CVD burden in the next 10 years in Asia will be inevitability because the trend, the rapid population aging and the increased population size will continue. According to the data provided by UN report, the population aging or the aging population are increased rapidly in the next 30 years. The increase in last 30 years then will increase even more rapidly in next 30 years in whole Asia, India, China, South Korea, and Japan. So there, in Japan, it's already very high proportion of population age more than 65. Then this proportion increased to close to 38% in Japan. Currently, it's 28%. Then in Korea, South Korea, this percentage will increase from 16% to 38%. China is 11% now, then we increased 26%. This percentage will double in India too. So we're facing a big challenge for population aging in the next 30 years. So we used to have a collaborative study with the Columbia University. Dr. Goldman and Dr. Murray, Andrew Murray. So we predict in China, then we model in the major determinants for CVD trend. Then we find a 50% increase CVD events, include the fetal and the non-fetal, from 2010 to 2020 would be displayed by population aging and growth. Only 23 by the increased risk factors. So that's the first feature and some implication. And the second feature is there is a huge geographic differences in CVD mortality in Asia due to the combined effect of the aging and other determinants. In this review, actually this is a central illustration. And this slide shows you the comparison of crude CVD mortality rate in the Asian country by region. You can find that in the Central Asian, East Asian, generally have a higher CVD mortality compared with the Southern Asia and the Southeast Asia. And the Western Asia, actually, the CVD mortality in this region have a great variation. Georgia have a highest CVD mortality in the whole Asia, and the Qatar have the lowest. It's 20 times the difference. It's very interesting to see what is underlying. I use a crude, did not use age standard, because I think the age standard rate actually underestimate the rate for the country with the aging population, overestimate the mortality rate for the country with the low resources and the low life expectancy. So I don't think that's reasonable. So we should consider age as an important risk factor in the future comparison. And the third feature of CVD epidemiology in Asia is a huge regional difference in the dominant CVD subtype. And the most the ischemic heart disease and stroke, those major CVD type. But in Central Asia, Western Asia, and South Asia, you can see that ischemic heart disease is a major cause, a major dominant type of the CVD. It's much higher than the percentage much higher than the stroke. But in East Asia and Southeast Asia, stroke is a dominant type of CVD. It's a proportion among the total CVD. Then you can see the comparison, the mortality rate comparison. You can see in the Central Asia, Western Asia, and the Southern Asia, ischemic heart disease is much higher than the mortality from stroke. But in Eastern Asia and Southeast Asia, it's in the opposite. The stroke mortality is higher than the ischemic heart disease in most of the country. The difference is not fully understanding now. And the first feature is the different Asian country actually in the transition stage of CVD epidemics. It's a little bit complicated, but I'm trying to show you the different socioeconomic stage with a different life expectancy. The country have different burden, different characteristic for the CVD epidemic. So it means a different challenge for the country. So I can roughly classify country into three groups. The stage one, the country means still in the early stage CVD epidemic. The group two is the stage with a very rapid increase in CVD. And stage three is the stage of degenerative disease. And if you see the characteristic for different stage, stage one, the country with a relatively low life expectancy still, then they have a relatively low mortality, CVD mortality rate. And in the stage 2 country, like China and some country, for most countries in the Central Asia and some country in the Western Asia, with a high and a very high CVD mortality rate. And stage 3, then you can find the CVD mortality is relatively low in Israel, South Korea, and Japan. It's all the cruel mortality rate. Then the second characteristic for the transition stage is the disease spectrum is more significant. In the first group, stage 1 country, you can find the infection disease. Infection disease still is the top cause of death, or take the substantial part in the proportional mortality rate. And the cardiovascular disease, in generally, the proportion is lower than 25%. And the cancer is the number of deaths from cancer is very small. But in the stage 2 country, they have very high mortality, CVD mortality. CVD is the top cause of death. In generally, it's accounted for over 40% of total deaths. The deaths from infection disease become very limited. The increased cancer deaths, but still much lower than the cardiovascular disease deaths. Then the last stage, the stage in Japan and Korea and Israel, the proportion of CVD reduced. The cancer become a top cause of death, and especially the dementia and other degeneration disease increase substantially. Dementia now already become the third or even second cause of death in Japanese population. Then if you see the prediction for the next 30 years, the population aging population will become is more than even the 1/3 population. I believe this characteristic is not only important for the country in the stage 3, also important for stage 2, stage 1, because as the socioeconomic development and the increased life expectancy, stage 1 is tend to become stage 2. Stage 2, we're going to go to the pattern of stage 3. And another characteristic is the proportion premature CVD deaths in Asian countries is different. It's higher, very high proportion of premature deaths in the stage 1 country, a little bit lower in stage 2 country, very low in stage 3 country. And also, most important, the life expectancy is lower in the stage 1 country, a little bit higher, generally is over 70 than in the stage 2 country, and over 80 in the stage 3 country. So I think that information is very important for the resources plan so I think they actually the country facing different challenges from CVD. And the last feature of CVD epidemiology in Asia is increasing epidemics and the massive burden of key modifiable CVD risk factor, along with the rapid progression of population aging in many Asian countries. So Asia actually now become epicenters for the major CVD risk factor that used to be in Western high-income country. A paper published in 2019 on Lancet evaluate the health effect of dietary risk in 195 countries. Then showing among the 10 healthy food or nutrition, few Asian countries, few Asian regions reach the optimal level, especially for the fruit and others. But among the 5 unhealthy food or nutrition, for all the Asian country, Asian region exceeded the sugar sweetened beverage. As the East country East Asia and Southeast Asia have exceed the sodium. It's very high in terms for intake for sodium. So the high sodium is the major cause of is have a major attribute. It's a major contribution factor for the CVD deaths in Asian area, in the East Asian area. And another important risk factor, you can see the important paper published on Nature in 2000. I actually is one of the co-authors for this paper. I joined this study by the NCD risk factor collaboration. It's showing how the epicenter for the high cholesterol change in these 40 years. So in the Western country, used to be have a very high cholesterol level, but reduced in the 40-year period. But some countries in China and other Asian countries have a significant increase the cholesterol level in their population, especially China. There is a large increase in the mean level of cholesterol in the population level. So the AI-CVD deaths attributable to high cholesterol level, non-HDL level in high-income Western country decrease substantially, but this number increased across Asia during this period, more than tripling in East Asia and more than doubling in Southeast Asia. And also we can find the repositioning for global epicenter of diabetes from 1980 and also predicted in the 2020. Even the diabetes is or increased epidemic in the whole world, but Asia is more severe. And currently is almost 50% global diabetes from just 5 Asian countries. So Asian is we can say is a global epicenter of diabetes. In this review, I also provide the first time is the comparison for especially for Asian country. I find those data in the World Health Statistics 2020. Then you can find the big variation in age standards, prevalence, obesity in Asian country. Kuwait have a highest prevalence rate, but Vietnam have a very low, just 2%. It's very interesting. And also you find the variation in the prevalence of hypertension in Asian country. But in generally, for the age standard prevalence rate, most Asian countries have a relative higher prevalence of hypertension. It's more than 20% in most countries. But this age standard prevalence rate is much lower underestimate the real burden of hypertension in many countries, especially the country with the aging population. Like China here, the age standard is only 19%, but actually we have more than 30% population have a hypertension. And also there is a huge variation among the smoking rate in Asian country. Myanmar, the population that is very highest smoking rate, and Oman have a very low smoking rate. But this smoking rate WHO provided is to use the whole population as a denominator. They didn't provide the smoking rate by the gender. It's men. I believe many countries, men have much higher smoking rate compared with women. And the most important risk factor is aging. So aging, the age used to we consider is as a risk factor we cannot modify. So that's why we always use the age standardized, trying to eliminate the impact from age. But based on the study we did and many other studies also present this result, the similar result. If the young people and the middle-aged people, they keep their all the risk factor in the optimal level, actually the impact, the green one, the impact from age decrease, not disappear, but reduce substantially. So that means age is a modified, we can modify the impact from age. And also I remember one of one of the 10 treatment by Framingham studies, they recognize, they conclude age is a risk factor, modifier risk factor. So before I finish my talk, I would like to share with you some 4C for the CVD epidemics in nation in next 30 years. So I believe the population who free from elevator CVD risk factor will increase, free from the risk factor will increase, as increase healthy lifestyle and the substantial improvement in availability and accessibility, prevention and treatment strategy in many Asian countries. And I believe the number of survival from ischemic heart disease, stroke, and the patient with heart failure will continue increase as they reduce the fatality rate from improved acute care and secondary prevention. And I believe ischemic heart disease may become a predominant type CVD in the Eastern Asia and Southeastern Asia. And I believe CVD in total deaths and CVD mortality will increase in stage 1 country like India and Pakistan and Nepal, or decrease in the stage 2 is like China and Georgia. But the cancer and the degeneration disease, such as dementia, may increase substantially in the population as the population aging. I believe the innovation in non-invasive the vessel evaluation, the technology, and the new technology in early atherosclerosis treatment will inspire new strategy for cardiovascular health and cardiovascular prevention in the era of long life. Thank you very much. If you're interested for this paper, you can visit our website or download this review for free. Thank you very much.
Thank you, Professor Zhao Dong, for your wonderful presentation. You provide an overview of the important epidemiological features of cardiovascular disease in Asia, current and future challenges in cardiovascular prevention implied by the epidemiology features in Asian countries are highlighted and discussed in your presentation. So now welcome Professor Wang, Nansen Wang, to moderate the panel discussion. Welcome you, Nansen.
Hey, well, thank you very much, Professor Wang, and I want to first congratulate you and as well as all your associate editors for the and your editorial board for the fantastic progress and great success of JACC Asia. It really has become the most significant cardiology journal in the entire Asian region in such a short time, and I have been very impressed by the articles that have come my way. So again, congratulations to you and your team for the great work, and also for putting on these important JACC Asia webinars. It's a real honor today to participate in this one on epidemiological issues in cardiovascular disease within Asia. I might first, before introducing the next speakers, I might first ask Dr. Zhao if she could comment on what she feels are the top 3 public health recommendations that could be made to combat the increase in cardiovascular disease epidemic throughout Asia. So whether it might be anti-smoking legislation or food package labeling, and how they relate to some of the key important emerging risk factors that are being responsible for the increased cardiovascular disease risk. And also, as a second short question, if you can comment on how you feel this very interesting transition of cardiovascular subtypes, as you noted, in South as well as in East East Asia, Southeast and actually East Asia, it's still predominantly stroke. And whether you feel that this is going to be transitioning to mainly ischemic heart disease in the next few years, and how this might relate to the epidemiologic transition stages that you point out.
Okay, thank you for your question, Nathan. I think that's a very important question, but I believe because the different Asian countries have different profile risk factor, they may have different the major issue for public health policy. In China, as the hypertension ranking as the first risk factor is the highest attribute risk for the CVD deaths, and the sodium, the over intake for the sodium is the ranking in the second, and the cholesterol, elevated cholesterol ranking in the third. I remember every year the China CDC ranking the major risk factor. So I think that for China is most important is move the policy to the upstream to increase to change to create environmental for the health food, health diet, include the label of the component for the food component, food labels. I think that's one of the important policy, and also increase the awareness rate, treatment rate, and control rate for hypertension is also important. And anti-smoking is another one. But for the other countries, like some country in the central, I remember southeast country, there is a low fruit intake is the top problem for the dietary factor. So, and I think it's very complicated. I cannot list is the public health policy is suitable for all the Asian countries. So it's my answer. And for the stroke issue, I think because it's most important risk factor for stroke, for hemorrhage stroke, is hypertension. But as the increased treatment rate, control rate hypertension in many of Asian countries, the hemorrhage stroke mortality reduced substantially. But the ischemic stroke still keep the increased trend in many countries. So for this reason, I think the cholesterol control is very important. Diabetes too.
Wonderful. Well, thank you so much. And I do think it's going to be very interesting to see, for example, as cholesterol issues become a greater problem in China, if that's going to eventually shift the transition more towards ischemic heart disease. So we'll see over subsequent decades. So we need to move on to our four panelists. And first of all, it's my great honor and privilege to introduce Professor Doraja Prabhakaran, who is currently the Vice President of Research and Policy of the Public Health Foundation of India and Executive Director of the Center for Chronic Disease Control in New Delhi. I've had the pleasure of knowing him for a number of years, and I also congratulate you on your recent Lifetime Achievement Award in Preventive Cardiology that you received at the Lipid Association of India, that I've been very, very fond of and participating with. So Professor Prabhakaran is going to be speaking on CVD prevention in India and what are the key strategies for the next 10 years. Welcome.
Right. Thank you, Professor Wang, for that very kind introduction. I hope you're able to hear me.
Yes, very well.
Okay, and you can see my slides too?
Yes, very well.
Okay, right, thank you. So what I'm going to do in the next 8 or 9 minutes is to talk about what are the preventive strategies that that are required in India to combat the huge burden of cardiovascular disease that we observe now. Before I start off, I just wanted to misquote Charles Dickens, who wrote The Tale of Two Cities, and he said, "It's the best of times, it's the worst of times" in the 18th century. So when you look at cardiovascular disease, it looks very similar. There have been tremendous achievements both at population and individual level. And we saw even in Asia, there's been a population level decline in CVD mortality, but not to the extent that we observe in the high income countries. So in the high income countries, we know that there's been a decline of more than 50% over one generation. There's been decline in acute myocardial infarction mortality from around 30% to 4% in 50 years' time, and substantial decline in cardiovascular risk factors. But we are plagued with uneven prevention policies. There's huge disparities in care within and between countries, lack of simple and essential drugs that are required for secondary and primary prevention are not available in many parts of the world, and there's gaps between best practices and delivery. So how do we reduce these gaps in CVD prevention? I think first thing we need is a comprehensive cardiovascular or chronic disease prevention program, because we work in silos. We talk about the prevention people don't talk to the clinical care people, and the clinical care people don't talk to policy. So I think we require to break down the silos and work together as a group. We need to address several multiple challenges that are there. One is the lack of good surveillance system in India, and we need to build a robust surveillance system, particularly the health management information system. And second is, I think most important is we need to give attention to upstream determinants. Professor Wang, you asked the question, what are the three important things you need to do at the policy level? And I think at the policy level, we need non-personal policy intervention in 5 domains. Number one, obviously, is tobacco control. And I think India has done pretty well in terms of tobacco control, particularly control of smoking, not so well in terms of control of non-smoking forms of tobacco. So that's number one. Number two is promoting a healthy diet in the population, particularly a balanced diet which is micronutrient sufficient across the lifespan. That's the second thing that we need to do. Third is mitigation of air pollution, which is a big problem in many parts of India and many parts of Asia, actually. Most of the highly polluted cities are in this part of the world. And I think policy measures are required to improve the pollutant levels, because right now we have shown and there are several studies actually to show a huge link between PM 2.5 and many of the cardiovascular risk factors. That's number three. Number four is improvements in physical activity, and we need to make an environmental friendly method of increasing physical activity. We need to provide an enabling environment to people. It's easy for us to say increase physical activity, but if the sidewalks are not there, or the sidewalks are used for parking of cars, the parks are used for criminal activity, then nobody indulges in physical activity. So I think we need to look at that aspect too. And the last, which is not addressed too often, is alcohol. Harmful use of alcohol is also an important determinant of cardiovascular risk factor, and that also needs to be addressed through policy measures. And I think these 5 policy measures can go a long way in preventing cardiovascular disease. The next thing that we need to look at is understanding the mechanism of disease. We saw from the JACC Asia paper that how each country is very different in terms of what is happening in terms of stroke and in terms of ischemic heart disease and the distribution of the disease. So the distributions of the disease is very different. Just to give an example, if we look at diabetes as an example, and if you look at 4 countries, this was published by the WHO in 2012. In US, for example, we have overweight or obesity as defined by BMI greater than 25 to the tune of 66% of the population. The diabetes prevalence was 9%. In 2012 in China, overweight and obesity was close to around 30% or so, but the diabetes prevalence again was 9%. In India, at that time, overweight and obesity prevalence was 13%, and the diabetes prevalence was 9%. Though clearly we are linking obesity to diabetes, there is a fundamental difference here in terms of as to why diabetes is so high and widely prevalent in Indians despite lower BMI levels. So we need to understand the mechanisms of disease very clearly, and we need research in those areas. And the most important thing is primary care. I think primary care is very central to the management of cardiovascular disease, and we require disruptive innovations. And I'll talk about it in a very brief way after this slide. We also need to build a cadre of independent researchers. We need to synthesize and disseminate information to policymakers, build large-scale collaborations, and we require ultimately a multidisciplinary and multi-pronged approach. So the thing is, we need to use technology as much as is available. We need to make technology very simple and use. I've shown you a menu of options. Obviously, policy takes precedence, but primary care disruption involves task shifting and use of technology. And I'm going to talk about telehealth. There's no time to talk about all of these. Work has been done in many areas. I'm just going to talk how telehealth can change and improve access to people. So we have created a telemedicine platform, and I thought I'll just talk very briefly about it, because barriers to telemedicine today is challenges in accessing telemedicine services due to literacy, language, or technological barrier among patients, lack of good clinical history, physical examination findings, and lab parameters that aid physicians in evidence-based decision-making, multiple innovations in digital health technology. There are many, but many of them are not interoperable. In the sense, like taking the simple example of a mobile phone, there are things which you can perform in an iPhone, which operates on an iOS system, versus an Android phone. There are differences. You require an interoperable system and put them on a single platform. So we created a platform which addresses all of these three, and we call it the assisted telemedicine, or Digi Sahayam, which means digital health. So essentially, we are upscaling skills of healthcare workers in providing assisted telemedicine, improving access to primary and tertiary care through trained personnel, improving quality of care through point-of-care diagnostic and electronic decision support system, and reducing the need for follow-up visit to health facilities, which actually is a good way of addressing the climate change and air pollution issue, and real-time monitoring and feedback mechanism that assure quality standards. So these are some of the technologies that we have paired in our telemedicine system. Empower is an electronic clinical decision support system, which is a knowledge-based system designed to support healthcare providers in delivering evidence-based care to patients visiting health facilities. This has been trialed over the last 10 years and has been used in multiple settings and multiple locations, and has been scaled up within the country, where physicians get a personalized management plan for the patients. Second is, we created a point-of-care diagnostic device which can immediately give some of the results. We are upgrading this to have lipid profile and cardiovascular disease biomarkers to be given immediately. The third device that we have is a cloud-enabled 12-lead portable ECG, which is a very small device, and it's FDA approved. And last is, we wanted to give eyes and ears to the doctors who are sitting remotely. So we have paired them with an electronic stethoscope and a high-definition camera. Now, this is how the portal looks like. So one is, it gives general physical examination findings, which are captured by the healthcare worker to the doctor. It also provides a template-based history, personal history, presenting history, and so on to the doctor. It provides vitals from visits with the trends, and provides lab results with trends, provides ECG readings, and provides electronic decision support system to several of the chronic diseases, and ultimately provides the e-prescription and a prescription history. It is also a markup for follow-up visit and has a markup for referrals. Like, this is an example of the doctor hearing the cardiac sound. Like, this is at this position, the second sound position where the doctor can hear. So clearly, creating a system in which the patient's access is improved is a very important thing. The second thing is, for this, the patient has to come to the clinic, because we are providing an assisted telemedicine solution so that literacy issues can be taken care of. But what about people who are not unable to visit the hospital? So we have created an on-foot telemedicine system. All our equipments can put into these two bags, and a person can go to the house and initiate a telemedicine consultation, both with a doctor and a specialist. The next thing that we have done is to set up kiosks, particularly for screening and surveillance. This can fit into a small suitcase, and it can be used anywhere in the say in train stations or metro stations, airports, etc., where we could set up surveillance or opportunistic screening programs. And last is hard to reach population where there are no places to examine patients. We could use something like this in a van where a clinic is set up and a telemedicine consultation can be done. So I just showed you an example of disruptive innovation. You require to do policy measures. You need to improve the drug availability in the multiple, particularly for secondary and primary prevention. But most important is to strengthen primary care through multiple mechanisms and using technology that is available. So this is my final slide, which shows from research, we have to synthesize that information that we get, disseminate the information, and we need to act on whatever we have found and scale it up and create a sustainable policy. So to make research effective, research is an important component of all of these. We need to fill critical gaps in knowledge, influence changes in policy that are informed by evidence from research, design and evaluate health programs for greater impact, and engage other stakeholders in society. So this is my last slide, and thank you very much for your patience.
Well, thank you very much. Thank you very much, Dr. Prabhakaran, for your really very interesting lecture, and very impressive to see all the accomplishments and progress you have made in the area of telehealth, which I think is really a very important area that is growing and will have a dramatic impact in the preventive cardiology field. So we need to move on to the next speaker, and it's my great honor to introduce Professor Jian'an Wu, who I realize I have known now for more than 30 years, since I believe we first met in Beijing in 1989 and again in Fuwai Hospital in 1993. And it's great to see all the fantastic work you've done over the years, Jian'an. And he is Executive Director and Professor of Sciences and Clinical Research at Peking University Clinical Research Institute, and also Professor of Epidemiology at Peking University School of Public Health. So Dr. Wu will speak on CVD prevention in China. What are the key strategies for the next 10 years? Welcome.
Okay, thank you, Professor Wang. And well, can you see my screen?
Yes, very good.
Okay, good. Well, first, good evening, everyone. And particularly, I want to thank Professor Jian'an Wang and Professor Dong Zhao for inviting me to participate in this great event and to address this important question. I think it's a big question, but I will just give my brief thoughts. I think those just my personal observations and opinions. I welcome any critiques from you. Here to talk about what we should do next 10 years for prevention and control cardiovascular disease, I think we should look back to see what we have learned from the past. This slide is showing you the change in cardiovascular mortality rate from 1990 to 2018 in China. It tells us the rate was increasing steadily in the past and will probably continue to increase in the next 10 years. But that does not mean we will totally fail in prevention and control of the disease. The different trend in urban and rural may tell us something. If we take the 10 years data from 1990 to year 2000 to extrapolate the trend to now, it should look like this dotted line, which is roughly parallel with the actual line for the rural. In fact, the major cardiovascular risk factors such as hypertension has been increasing in China in the past decades, showing here in this orange bars. That, that should have driven the CVD mortality increase with the same trend in both urban and rural. Thus, take the dotted line and the line for the rural as control. We should consider the slowed down in increase in cardiovascular mortality in urban as a great success. But where does the success come from? If we compare the awareness, treatment, and control of hypertension from 1991 to 2002 and further to the most recent data, each period covered about 10 or 11 years. Compared with the first 10 years, the second 10 years had significantly more increase in awareness, treatment, and control, with 17%, 17%, and 9% versus 3%, 12%, and 3% respectively. And the improvement in awareness, treatment, and control took place significantly more in urban than in rural. Since 1999, the Chinese hypertension guidelines has been updated roughly every 5 years to reflect the most advanced knowledge and technology in prevention and treatment of hypertension. More important, the hypertension guidelines for primary care was developed and issued with the endorsement of the Ministry of Health in 2002, indicating China started to shift the task for hypertension management from tertiary care to primary care after year 2000. The most important is the political transition. A transition from a GDP politics to a people's livelihood politics. With the new political trends, a series of healthcare reforms were made. Development of community health system was set the priority. China established a new rural cooperative medical scheme to cover the medical expenses for farmers, which accounts for half of the total population. The basic public health services package was established to provide free services for control of 10 diseases with major health threats and increase the health equity. With new rural cooperative scheme, people covered by medical insurance to some extent increased to over 95%. The government compensation to new rural cooperative scheme increased by 10 times in 10 years. Government investment in basic public health services also increased dramatically. These were all contributing to the prevention and control of CVD and other NCDs. To talk about what should be done in the next 10 years, we should apply the knowledge that the global science community has created and accumulated during the past. The knowledge tells us that to triumph over cardiovascular disease and other NCDs, we need a healthcare system that could provide whole life scale, whole life cycle, continuous services, including primordial prevention that address our living environment, primary intervention that addresses our unhealthy lifestyles, secondary prevention that addresses the risk factors that already developed in our body, and tertiary prevention that addresses the disease itself. In year 2016, Chinese central government launched the Healthy China Initiative as one of the 4 national development strategies of the country. It includes 15 action plans that covers whole life cycle health management and focus on primary, secondary, and tertiary prevention. Thus, for the next 10 years in China, I think what we need to do is just to implement the Health China initiative steadily and firmly. There are 3 principles that we should follow in implementing those strategic action plans, I think. First, we should continue to do what has been proved right. In particular, we should continue the healthcare reform to further strengthen the primary care. Second, we should widely apply those real low-cost, scalable interventions and focus on mass health education and healthy lifestyle promotion. Finally, we should be innovative enough. New technologies such as wearable, mobile, non-invasive, artificial intelligence, etc., will provide unlimited possibilities. My dear friend Prabhakaran just showed you many cases, but I think there will be many more coming on the way. Okay, thank you for your attention.
Thank you very much, Professor Wu, for your very interesting and nice lecture on CVD prevention in China. And it's great to see the progress China has made in preventive strategies and look forward to the future developments. So it's now my pleasure to introduce Professor Tomonori Okamura, who is Professor of Preventive Medicine and Public Health at Keio University School of Medicine, Director of the Japan Atherosclerosis Society, the Japan Epidemiological Association, and the Japan Health Insurance Association. He's also Deputy Editor-in-Chief of the Journal of Atherosclerosis and Thrombosis. So, Professor Okamura will be speaking on CVD prevention practice in Japan, focusing on primary prevention. Welcome.
Thank you very much. I'm very happy to be here. Very thanks to Professor Wang. So my topic is CVD prevention practice in Japan, focusing on primary prevention. I have no COI for this topic. First of all, I introduce an absolute risk assessment for atherosclerotic disease prevention. Estimation of the absolute risk, in other words, real probability for a future CVD event, which was calculated by major risk factors, is very important for prevention. For the purpose, clinical scores based on stratification by risk factors, such as Framingham scores, very popular worldwide. It can be more easily understood by patients than relative risk. This is Japanese guideline, and this is US, and this is Europe. All guidelines use the absolute risk assessment. So, I introduced an absolute risk assessment to Japan Atherosclerosis Society guideline. We have an established guideline for hypertension and diabetes. However, today, time is limited. I introduced a guideline for this epidemic in Japan. The incidence of coronary artery disease is quite different between Western countries and Japan, which is lower in Japan, as you know. In 2012, Japan Atherosclerosis Society has published a guideline for general practitioners with absolute risk assessment for the first time to estimate CAD deaths. In the current guideline, revised in 2017, individual risk assessment and repeat management goals have been determined by CETA score predicting CAD incidence. CETA study is a cohort study to clarify the cause of cardiovascular disease managed by National Cerebral and Cardiovascular Center, which has been performing this cohort study in community setting. The CETA city is located near Osaka City, which is the second largest metropolitan area in Japan, which includes also Kyoto. About 12,000 residents living in the city, aged 30 to 79 years, were randomly selected from the population registry. Of these, about half of them attended the baseline survey between 1989 and 1994. This is the publication list of concerning traditional cardiovascular risk factors in the CETA study. Hypertension, we have already published risk of hypertension, dyslipidemia, smoking, diabetes, CKD on cardiovascular disease in these papers. After that, we developed CETA score for the JACC guideline in 2017, which was published in, originally, which was published in 2014. We estimated these factors, and finally, we calculated estimated incident risk of coronary artery disease within 10 years. This is a flow chart for setting management target for LDL cholesterol. For the first time, we can check whether the patient has past history of coronary artery disease. If yes, they classified into secondary prevention category. After that, we check the present existence of DM, diabetes, CKD, non-cardiogenic cerebral infarction, and PAD. If yes, they automatically categorize into category 3. It means high risk. After that, we can calculate 10-year probability of CAD incidence derived from CETA score. And then they are categorized in category 1 or category 2 or category 3. The cutoff point of CAD incidence was 2% and 9%. In Japan, 9% and over of 10 years risk of CAD incidence categorized as classified into category 3, which means high risk. And this table shows the repeat management target for patients with different risk levels. For primary prevention, we have different repeat management target for LDL cholesterol. For example, in category 1, it means low risk. The target level of LDL cholesterol is under 160. If they are classified into category 3, the management goal was set as 120 under 120. If secondary prevention status, the target goal is under 100. So Japanese Atherosclerosis Society supply free application software for risk scoring. So we can easily download this program in our smartphones, even in Apple or Google. By the way, let me introduce Japanese medical insurance system. Medical insurance system in Japan requires the enrollment of all Japanese residents. We call this health insurance for all, which was established in 1961. It consists of 3 major insurance systems for employees, self-employed, and the elderly, which were managed by different insurers. This system allows all Japanese citizens free access to all medical services with a self-pay rate of 30%. However, prevention is not included in the health insurance system, which is managed directly by an insurer itself. Our current public strategy for primary prevention depends on act on assurance of medical care for elderly people. It is all insurers in Japan implemented a program to prevent obesity, diabetes, and CVD through health checkups, health guidance, and so on. Every year, these health checkups, named for specific medical examination, are available to all citizens aged 40 to 74, almost free. Now, about 55% of all Japanese in this age group, about 30 million people, has attended this examination. And these are check items for annual health checkups in Japan, named for specific medical examination done by insurers. These items includes major risk factors such as blood pressure measurement, serum lipid levels, and fasting blood glucose or hemoglobin A1C. Annually, Japanese citizens get this examination almost free. And these items includes examination of height, weight, and waist circumference, because this system mainly this checkup system is targeting to diabetes and obesity. This is current. These are current issues and future directions for prevention in Japan. First, present system for specific medical examination is biased toward prevention for overweight, obesity, and diabetes. As you know, Japanese population is very low prevalence of obesity. However, this system biased to prevention for obesity. And the health guidance is only recommended for participants with increased waist circumference, overweight, or obesity. Second, introduction of absolute risk assessment, including lifetime risk, is needed in specific medical examination. Third, exploring new biomarkers to detect high-risk individuals, however, which is to be sustainable in primary prevention for all. And this is conclusion. Current Japanese prevention programs have achieved a relatively high participation rate for specific medical examination, which may be associated with longevity of Japanese. However, to date, there is no link between academic guideline and public prevention program by insurer. Revision in public prevention program is warranted. Thank you for your attention.
Thank you very much, Professor Okamura. A very nice talk, and great to see your public medical examination program. I think that has great potential for prevention. Okay, so we need to move on to our final speaker of the panel, Professor Jian'an Kim, who is Chair and Professor of the Department of Preventive Medicine at Yonsei University in Seoul, Korea. Also visiting professor at Osaka University, Chief Data Officer at Yonsei University, and Vice Chair of the Korean Preventive Service Task Force of the Ministry of Health, and Chair of the Hypertension Epidemiology Working Group. for the Korean Society of Hypertension. So Dr. Kim will present on CVD prevention practice in Korea. What are the key strategies for the next 10 years? Welcome.
Thank you for inviting me to this important discussion. Can you see my slide? Okay. First of all, I enjoyed wonderful review by Dr. Zhao about the epidemiology of CVD in Asian country, and I also enjoyed data from India, Japan, and China. I show some national epidemiology data from South Korea. Korea is often considered one of the countries where cardiovascular mortality is rapidly decreasing. According to the Global Burden of Disease Study Database, age standardized cardiovascular mortality in South Korea decreased by almost 80% since 1990. It is not only the fast decline, but also it reaches to similar level to Japan, which have the lowest cardiovascular mortality rate currently. However, actual number of deaths from cardiovascular disease is not decreasing, and recently it started to increase again. But this is mainly because of the rapid population aging in Korea, since Korea is the fastest aging population in the world. So I want to point out 4 challenges for CVD prevention in Korea. First, we must respond to changes in subtypes of cardiovascular disease. In Korea, stroke mortality peaked in 1990s, then started to decline very fast, and it is still decreasing. Ischemic heart disease mortality peaked in mid-2000, but thereafter there is not so big increase or decrease. However, heart failure mortality has recently started to increase, and the increasing speed is very fast. When divided by age groups, stroke mortality is rapidly decreasing in all age groups. Ischemic heart disease mortality began to decline from 1990 in middle-aged group, but in elderly group, it started to decrease about 10 years ago. However, for heart failure mortality, it is increasing very fast, especially in elderly group, and more fast speed in elderly women. And second issue I want to talk is of risk factor of cardiovascular disease. Smoking rate is decreasing. Hypercholesterolemia and diabetes are increasing in Korea. Prevalence of hypertension did not change much, but the prevalence itself is highest for hypertension. Actually, the prevalence of hypertension did not change much before or after age adjustment in Korea. However, the people who visit doctors for treatment of high blood pressure increasing very fast, from 3 million in 2002, currently almost 10 million people. And also the people who use antihypertensive drug increased 4 times since 2002. And most importantly, people who persistently use antihypertensive drug increased more than 10 times since 2002. So as a result, awareness, treatment, and control rate of hypertension in Korean population increased very fast. But the increasing speed is attenuated recently. And as a result of this change, the population mean blood pressure level of the Korean population has been decreased. And currently, according to the NCD risk factor collaboration, Dr. Zhao already introduced NCD risk factor collaboration. I also joined this collaboration 2 years ago. And according to their data, currently the South Korean population showed lowest prevalence of hypertension and lowest mean blood pressure level among the 200 countries which were included for NCD risk factor collaboration. However, probably due to the aging population, the absolute number of people with hypertension in Korea is increasing. And more importantly, the number of elderly people with hypertension is increasing, and the increase is more prominent in female elderly. So fortunately, the number of people with controlled hypertension indicated by green colors are increasing very fast. But still, we have considerable number of treated but uncontrolled hypertension and also undiagnosed hypertension. And the pattern is a little different for women and men. And in addition, a large number of people have multiple cardiovascular risk factors, in particular in elderly group. Most of the elderly people have at least 2 major cardiovascular risk factors. And when you divide by age group, in the elderly group, women have more cardiovascular risk factors compared to men of the same age. The third issue I want to mention is personalized prevention strategy. Dr. Okamura introduced the risk assessment and guideline from Japanese Atherosclerosis Society. But in Korea, both in the dyslipidemia treatment guideline and the hypertension treatment guideline, the risk stratification is still based on number of risk factors, not on the risk calculation. So we need to develop precise risk assessment tool for the Korean population and to develop personalized prevention strategy based on the risk assessment. The last thing I want to mention is inequality in cardiovascular health. Overall, Korea's inequality index is not so bad compared to other countries. Looking at the treatment level of hypertension, the persistent treatment rate in Korean population increased in all income groups. So currently, there is only little difference between income levels. However, our study shows that people with low income and hypertension still have significantly higher risk of mortality compared to highest income group, even though they have good medication or adherence. So we need more study about income inequality in cardiovascular mortality. In addition, socioeconomic inequality in the prevalence of major cardiovascular risk factor is widening for obesity, hypertension, diabetes, and smoking. in summary, to achieve better CVD prevention in Korea for next 10 years, we need to respond to changing subtype distribution of cardiovascular disease, and we have to care about the increasing number of elderly women who have uncontrolled hypertension, have multiple comorbidities. And we need to develop personalized prevention based on the precise risk assessment. And we need more effort to resolve inequality in cardiovascular health. Thank you for your attention.
Well, thank you very much, Dr. Kim, for your wonderful overview of prevention efforts in Korea. So it's now my great pleasure to turn this over to Dr. Eugene Yang from University of Washington, who will moderate our panel discussion in the remaining time. Dr. Yang.
Thank you, Dr. Wang, for the introduction. And I want to thank all the speakers and panelists, and for Dr. Wang for inviting me to participate in this, I think, really informative session. Since we don't have a lot of time, I think what I first want to say, I think what is interesting is listening to the speakers from various levels of income and using Dr. Zhao's really insightful review as sort of a background. I think we can clearly see what Dr. Zhao pointed out, that the phase of where the countries are with respect to the stage of cardiovascular disease in these countries is certainly reflective of some of the policies and challenges that are unique to each of these different regions. And so, you know, when we look at Dr. Kim's presentation of Korea, where degenerative disease is more prevalent now, and where the opportunities are going to be very different than, let's say, in countries like India, where they're in the rapid growth phase of cardiovascular mortality, I think is really interesting. So what I want to do, I think, is maybe ask a question for each of the speakers. And so maybe I'd first like to ask Dr. Prabhakara from India. I think, you know, your idea of implementing telehealth strategies, especially in light of the current pandemic, is really, I think, interesting, and certainly makes a lot of sense. I guess one of my questions is, I know that you've created sort of a framework to how to address this at various levels of access to care, but I do wonder if that is really the low-hanging fruit, because technology is challenging in terms of economic disparity. And so my question is really, is telehealth in the context of where India is with respect to cardiovascular disease the best strategy, or do we need to think about things more at a population health level, such as what we started to introduce in the United States with the recent FDA guidance on reducing sodium through dietary strategies from, like, let's say, restaurants and food processing companies, or, for example, the poly pill, where there seems to be, at least better data that suggests that there may be improvement in clinical outcomes with addressing hypertension, lipids through a more cost-effective strategy. So I would really like to hear your thoughts about this. Thank you.
I think, thank you for that question and your observations. I think you hit the nail on the head. The five best strategies, as I pointed out, are non-personal policy intervention, which address upstream determinants. So tobacco control, the dietary policies in terms of sodium restriction and trans fat reduction or trans fat abolition, improving physical activity, reducing harmful use of alcohol, and mitigation of air pollution should take primacy. But the fact is, the other things that you pointed out, that includes polypill, management of hypertension, were all low-hanging fruits, but the uptake, we know that we have a lot of evidence both for secondary and primary prevention, but the uptake of these secondary prevention strategies or the primary prevention strategies are very low. So we require some ways of implementing them. And I think telemedicine is one way of doing it. So that enables access to patients both to the primary care physician as well as beyond. And we have actually put these telemedicine not in affluent places, but in slums of Chennai and other places where it's being used and welcomed.
Great, thank you for your comments. Dr. Wu, so I really enjoyed your presentation. I think, interestingly, there's very similar, I think, common sort of ground between your discussion and Dr. Prabhakar's discussion about sort of primary care access, also interested in sort of looking at new technologies. But I like the comment that you made about low cost. And so again, in a country as big as China, similar to India, when you look at sort of the opportunities for, probably having the most consequential effect on improving outcomes, what do you think the strategies are that are going to be most useful? Is it, I know China has this very, I think, aggressive policy of primordial prevention to tertiary prevention, but what do you think will have the greatest impact in a country as large as China to try to really change, sort of the scale of progression of cardiovascular disease in your country?
Thank you, Professor Yang. It's a great question. I think, as you mentioned, China is a big country with a big population, and particularly, if we use any of those effective intervention that to be applied across the country, that must be low cost, because the average GDP per capita, still quite low in China, although the total economy is pretty high. But that for disease prevention, those actions must be taking effect for every single individual. It's not for the country as a whole. So the per capita GDP actually is more makes sense. So that we should carefully select those effective, affordable, cost-effective interventions. I think for those WHO best bias, that including smoking cessation, salt reduction, hypertension control with very low cost medication, those generic drugs currently available in China, and also the government recently actually implement a new policy that called the volume-based purchase policy for those medications that greatly reduced the cost for the clinical management of hypertension. So that actually make the primary care, that can cover as many as people, for with high blood pressure. I think again, I think in looking back to the past history, I think although we did a lot, but to me, I think that the most impactful change is we decide to shift the task for managing hypertension patients from tertiary care into primary care. And a lot of policies, and including Chinese cardiology societies, they put a lot of effort into training the primary care providers to manage hypertension, just around themselves. The patients just living in the household nearby, that being convenient. Is the access to the specialist would be difficult, and actually, so I think that is the most important and correct strategy we took in the past, and that should be continued in the future.
Great, Dr. Wu, thank you. Dr. Okamura, I think, Japan being one of the more advanced countries with respect to cardiovascular disease, clearly there's a sort of a change in terms of the perspective and sort of the way that cardiovascular disease is addressed. I think one of the things that we face that's a challenge is I would say the lack of uniformity among clinical guidelines around management of blood pressure, cholesterol. So the Japanese blood pressure target versus the Korean blood pressure target versus the American blood pressure targets are all different. And I was struck a little bit by the lipid targets in Japan. So I'm wondering a little bit about why or how. I'm sure it's based on the studies from your CITA sort of cohort, but I'm curious, have there been sort of thoughts about taking a more aggressive sort of approach in terms of LDL targets in Japan? Because they seem to be much less aggressive than many other parts of the world. So perhaps you can comment on that.
Thank you very much. And so Japanese guideline. So now we have many guidelines for each risk factors. So integration is we have needed for integration for separated guideline for the next time. And so still our main target is hypertension because Japanese diet is seems to be healthy. However, it includes much salt, even in still now. So the changing nutrition intake should be improved to prevent hypertension. And we are in a more and more aging society. And in the next step, we need some challenge to other type of cardiovascular disease, such as heart failure. And also, we need counteraction to dementia. This is a new horizon for no country do not face to. So we have now challenging status because almost 1/3 of our population is aged 65 and over. It is very tough time for us. However, now we have to continue to improve my prevention program in this new challenge. So it is very difficult to answer your question for all aspects. So it's my answer. Okay.
Thank you, Dr. Okamura. And Dr. Kim, I think it's your group that's working on trying to create a Korean cardiovascular risk calculator. So I think your discussion about sort of hypertension, I think the common thing I'm hearing from everybody is that, the most important thing that we need to address, frankly, in Asia is hypertension. And in your talk, you show, that there isn't, interestingly, a lot of variability with respect to adherence, but there's differences in terms of outcomes between sort of the lower income versus the higher income populations. In terms of the sort of risk tools, how do you think that will be established and when? And do you think that there are going to be similarities to other guidelines that we're using, such as the pooled cohort equation or the European score 2 system that now exists to help with risk stratification? Because I do think that that's sort of the next level of individualized cardiovascular risk assessment that Korea currently doesn't have. So what do you think is the horizon before that sort of implementation will occur?
Good question. Actually, even in Korea, there are some studies about the CVD risk prediction tool, someone from my group and someone from other groups, but many Korean guidelines just recommend the use of a risk calculator, but they do not adopt the risk calculation in the guideline itself. There are many concerns, but one is even though we have some risk prediction tool, they are not thoroughly validated in other cohorts because we don't have enough cohort data in Korea. And one thing is most of the risk prediction tool was derived from health screening centers. So maybe the representative issues. So my group developed the Korean version of a pooled cohort equation. We used several community-based cohorts in Korea. We are preparing to publish the result. And one thing, even though we have the representative risk prediction tool, we have another issue. Because the absolute risk of instance of cardiovascular disease is very low in Korean population, even if we use the good risk calculator, most of the people were classified to very low risk.
Oh.
So we cannot identify high risk population. So my group is trying to make the lifetime risk approach. In the Korean population, most of the CVD instance increasing after age 50 or age 60. So 10-year risk, we cannot identify the high risk group enough. But if we use the lifetime risk calculation, we can more efficiently identify the high risk group. But actually, both Korean Society of Hypertension and Korean Society of Atherosclerosis and the dyslipidemia are preparing to revise our guideline. In both guidelines, there is a big debate whether or not to adopt the risk assessment tool.
I think it sort of shows, especially with Dr. Okamura, showing sort of a high risk group being above 9%, reflecting the fact that the differences in terms of how high risk is defined is very different because the prevalence of disease is definitely very different based on sort of countries of origin, which Dr. Zhao pointed out in her great talk. Well, I think this was really a great session, and I really enjoyed the speakers, and I've learned a lot. And I think probably what my takeaway is, if we have low-hanging fruit, it's really that we need to be more aggressive at figuring out ways to address hypertension, since that is really the common thread that we've all talked about among the shared experiences from our individual countries. So with that, I will conclude my portion, and then I'll take it back to Dr. Wang. So thank you guys for your excellent presentations, and Dr. Zhao, excellent job.
I would personally like to thank all the speakers, Dr. Yang for co-moderating, and Dr. Wang for his great leadership of JACC Asia and these webinar series, along with Dr. Zhao. And hopefully we'll have future opportunities to meet together again, because I think it's great for all of us to share ideas about what works in prevention, and we can really learn a lot from each other from across the oceans and across the continents about strategies at both the population and individual levels that work best for different societies. And we can all learn a lot from all of you in Asia about how to do things better here in the United States as well. So thank you all again very much.
Okay, thank you all for joining us, all the wonderful speakers, panelists, and all of audience. So see you next time. Thank you all.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you very much.
Thank you so
Bye-bye.
much.
Thank you.
Uh,
Bye.